Ayush medical officers at co-located units are often diverted to ancillary hospital duties. As far as the mainstreaming of Ayush component is concerned, the Ministry of Ayush, as you may be knowing, that we are supporting the medicines component, we are supporting the infrastructure component, and other component, that means basically the deployment of the manpower as far as the training is concerned, which is supported under the NHM. So the main mandate which is given to them is mainly to undertake the public health programs, specifically to support the public health programs. But along with that, many a time the state governments, due to one of the reason, maybe the enabling guidelines are not percolated into the lowest level of PHC or CHC or district hospital. That may be the reason that they are utilized for not for the Ayush related their functions, particularly the OPDs and IPDs they are not able to do it. So that has to be very clearly, you have to instruct, being the head of the department of the state governments, particularly the principal secretaries and mission directors should clearly instruct wherever the co-location is happening. Whenever the national Ayush missions are providing the funds, definitely the Ayush doctors should specifically do the justice to the Ayush systems of medicine primarily. Then they can participate in the public health programs in collaborative manner. So that is the spirit of the mainstreaming of Ayush. Then salary disparity, significant pay gap between Ayush and allopathy medical officers, affecting morale and retention. Then untapped potential of Ayush systems at a community household level for preventive care and health promotion. Then this is very important. That is what for the last 2 days, we deliberated whether there is any mechanism to identify a pre-primary healthcare system, whether we can develop, whether India can make a leadership in that area, so that at least every household can have that kind of empowerment with preventive and promotive healthcare of the Ayush, Ayurveda, yoga, these systems, how it can be effectively inculcated into the daily habits of our household members. Isolated manner it is happening through school health program, whether it is a women child health programs and other things. Many programs are actually fragmented. In a very comprehensive manner, as a national mission mode program, just like Har Ghar Ayur Yoga, whether we can expand this program to the nook and corner of the country. So that is one of the important vision that we have to bring to the forefront, so that this can be made into a mass movement. Untapped potential of Ayush systems at a community household level for preventive care and health promotion, community awareness, limited public knowledge about the availability of the Ayush services at the co-located facilities, limited understanding among allopathy practitioners about Ayush benefits. So this is the area where Professor Gangadhar sir already mentioned that some kind of cross-learning modules, even integrating the Ayush into the family medicine, particularly the UG level, even after the PG level, Ayush can be appropriately integrated, and NMC and NCISM can take the lead in that curriculum and its implementation. The major suggestions brought forward by this group: expedite development of standardized comprehensive guidelines and SOPs for collaborative case management, referrals and joint treatment, promote holistic preventive pathways leading to citizen empowerment, joint training and capacity building, introduce common training modules, CME programs, and workshop for the Ayush and allopathy practitioners to encourage teamwork and mutual respect. The commissions are actually working on the mandatory credit as well as for the graduates who, if you want to renew their registration, then definitely this certain number of CMEs should be taken mandatorily. So that kind of thinking, if you are implementing in the whole country, I think our medical practitioners will be always renewed as far as their practice is concerned. That is very dire need. However, the implementation is required to be done by the states. Then strengthen service delivery, establish teleconsultation services for remote areas, run state-specific IEC campaigns, expansion of the co-located facilities, financial and HR measures, clarity in roles, responsibilities for each post, introduce difficult area allowance for Ayush staff in remote locations, particularly in the northeastern states, hilly terrain. These also brought forward by the states as specific recommendations. integration with the national programs, particularly formalize Ayush involvement in the national health programs, avoid duplication in programs, and promote unified convergence pathways. VK polls are very specifically mentioned wherever the programs having the similar objectives are there. There is a need to converge it, particularly the school health program, these RBSK and Ayur Vidya. These programs can be appropriately integrated so that the same beneficiaries will get a convergent and very strengthened program benefits. Then PMJY, this is the ministries are actively taken this issue, and it is hopefully it is under finalization, and we can expect some integration to the PMJY to the Ayush systems. Outcomes and way forward, nationwide adoption of Ayurveda and Yoga as a pre-primary healthcare model with household as fourth tier of healthcare. Develop detailed IPHS guidelines for co-located Ayush facilities. In fact, we discussed that actually there is a need of more detailed IPHS standards for even for the co-located facilities. So, Ministry is trying to finalize that also in consultation with the Ministry of Health and Family Welfare. Policy level intervention for cross-disciplinary courses like integrated UG course and MD in integrated family medicine, digitalization of Ayush system intervention from field to state, national level in collaboration with the Ministry of Health and Family Welfare, leveraging Ayush institutions and development partners for knowledge management, research and development for integration. The third sub-theme was organizational structure review, including HR strengthening and capacity building, variable or absent Ayush departments, lean structure of SPMU and DPMU, no BPMU, absence of an institutional body for technical support to the NAM, and lack of training and capacity building structure at the state and district level. As far as the workforce and recruitment is concerned, ambiguous recruitment policies, insufficient sanction post. Our Honorable Minister has taken very two specific points in the context of, one is about the establishment of the ministries in the states and those UTs without a legislature, at least the departments. So that will make a growth spurt in the entire Ayush ecosystem. Another point Minister has very specifically flagged is about the sanctioned post. Large number of Ayush hospitals are actually supported by the Ministry of Ayush under 50-bedded integrated Ayush hospital category. The regular post, if you are not able to create the post, regular post in that hospital, definitely you cannot sustain the functions of the Ayush hospital with only contractual hospital for a longer duration. Therefore, it is the prime duty of each state and UT government to create the necessary minimum post of the sanctioned regular post of various categories to that hospital, so that a perspective plan accordingly you can lead that hospitals into completely functional status. Then no clear career progression pathways, lack of uniform HR policies and promotional bottlenecks, absence of standard training modules, skill gaps. As far as trainings are concerned, actually training happens very clear. Various kinds of trainings are happened in a different segments and different manner. But whether we have any organized training, what you call institutional mechanism, training strategies there, apart from the regular teaching institutions, whether you have any specific training institute in your state. So that also you can look into that for entire Ayush training program, whether it is the technical training, reorientation training, induction training, or even for the various kinds of management skills, whether any particular institute can be accorded a nodal institute for the Ayush training. So that is very important. Kerala has done that model, that they mentioned that they have identified a state institute for a specific all kinds of training program. So I think all other states can come forward to undertake these training activities. At least if you are not able to create immediately one, at least assign these functions to one specific institute and appropriate additional staff and other things you can appoint them, so that all kinds of training activities, including the training assessment, training need, and conducting of the training, and even the monitoring of the training program, and also not only the monitoring, even deploying the manpower which has undertaken that training program into the institutions. Similarly, absence of this already mentioned. Establish Ayush ministries and departments in all states and UTs. Restructure SPMU, DPMU, these are the suggestions, and development technical support structures at state and national levels. Set up a dedicated training centers. Standardize service with IPHS norms. Create essential posts, restructure cadres, and you may be knowing that Ministry of Ayush also published public health management cadre guidelines for the Ayush systems also. Ministry of Health and Family Welfare previously published PHMC guidelines for the health workforce, and Ministry of Ayush has taken up that with the Ministry Health, and accordingly our sub-cadres has already been identified and it has been inducted into the PHMC guidelines. Now the implementation should start. We will not say that within 1 year or 2 years you can make any specific cadre, but at least you can begin with a general duty medical officer cadre in your state. Thereafter you can come to the teaching cadre. Then next stage, as and when your specialist hospitals are actually improved in functionality, you can create the specialist medical officer cadre also you can create. So based on the guidelines given by the Ministry of Health and Family Welfare for Ayush, you can make a very specific public health management cadre is also functional in your state. Implement the HR, MIS cadre specific training and dedicated HR cells in the directorates. Enhance curriculum with the integrated Ayush allopathy modules, blended learning, case-based workshops and clinical rotations. Similarly, strengthen faculty development through collaborations with IA. This institute are conducting various kinds of training programs to even for the medical officers, even for the field level officers under various programs. So your state can also avail these facilities, and even the research councils, WHO centers and cross-system mentorship. Provide management training in leadership, budgeting and data-driven planning for PMU staff. Promote inter-system sensitization through allopathic doctor orientation and annual integrative health symposiums. Upgrade facilities with the minimum infrastructure standards. Ensure essential staff, recruit contractual staff under NAM, and adopt state-level training calendars with NHSRC or similar organizational support. Then the organizational structure reforms, outcomes and way forward. Separate Ayush ministries and department at the states and UTs. Strengthening and restructuring of all these points already mentioned. Ayush workforce strengthening and capacity building dedicated workforce for Ayush outreach activities. Outreach activities, some of the recommendations are there. Actually, there should be dedicated manpower for all the outreach activities in the public health program. Even though we have mentioned only one nodal person, that may not be sufficient to cater the various divisions you are taking up for conducting the public health program. That is taken into consideration. So we hope that when mission guidelines, appropriate additional manpower also may be required along with the medicine support even for the public health outreach activities. Similarly, expected vacancy filling, functional integration of Ayush with the public health system, implementation of robust HRMIS, development of uniform training module. Then the fourth sub-theme, quality services under Ayush facilities including infrastructure, IPHS, Ayush standards and healthcare delivery is concerned. We have no technical wing for infra planning, HR ceilings, restricted post creation, space constraints in co-located units, because as far as the quality is concerned, ultimately it is derived from various factors including HR, space and even the medicines, and these aspects should ultimately define what is the quality. So based on that, many hospitals run in temporary rented buildings like basic amenities. So only you have to prioritize where you want to do based on the existing patient footfall. What's the expected patient footfall? What is the geographic area? IPHS have defined very clear guidelines for the population to be covered by each healthcare facilities. Based on that, you have to make perspective planning, and based on that, what are the existing infrastructure available in the state, you have to make the appropriate planning, and that should be reflected in the state annual action plan, and based on that, financial resources should be utilized. Irregular supply, delayed procurement, weak quality control and limited drug testing capacity, insufficient budget for sampling or inspections, and underuse of the NABL laboratories and accreditation laboratories have been recognized under the various provisions. Even the drugs and cosmetic rules also
recognize private drug testing laboratories. Somehow the drug testing is actually happening in the field is very abysmally low. So that enforcement mechanism also should be important. It need not be mandate testing of the drugs. Even the voluntary sample testing can be very effectively utilized so that the quality consciousness in the field, all stakeholders, whether it is manufacturers, whether it is in the public who use the medicines, everybody will be assured that these are actually periodically tested so that the medicines are of that kind of quality. Slow IT integration, manual reporting, weak EMR and telemedicine adoption, and low digital skills. Fast track approvals, these are the main suggestions. Fast track approval, special recruitment drives and flexible HR budgeting under NHM and NAM, establish new Ayush paramedical institute. That is also very highly relevant, not only for this country, even for the abroad. There are a lot of demand for the Ayush therapist, that we have to understand that there is a huge demand wherever the wellness centers are established in abroad, particularly Eastern European countries and even the Middle East countries and many other countries. That demand is actually generated, but whether we are able to cater that requirements. So if you want to earn this country having a lot of, if you require our Ayush system has to be boosted, definitely kinds of approaches we have to do. Set up new hospitals and colleges with the modern labs and facilities, use telemedicine, EHR and HMIS and mobile apps for service delivery and digital integration, strengthen procurement with fixed timelines, proper storage and quality dashboards, empanel NABL labs for testing and improve compliance monitoring, develop referral systems with allopathy, involve local governance and conduct facility audit. Auditing is also very important as far as the successful program implementation. So timely audit, not only the financial audit, even the technical audit of facilities are also very useful. Create interdepartmental committee and introduce FMR code for transparent fund tracking. So the way forward is develop IPS compliant Ayush infrastructure with the dedicated civil works cells, fill sanctioned HR posts and institutionalized training with the CME credits, expand Ayush in PHCs, CHCs and integrate with the national programs like NPCDCS, establish state-level quality assurance cells and strengthen research collaboration with the CCRIS, IA or NIA, etc. Ensure robust digital backbone, ABDM compliant Ayush HMIS for real-time monitoring and evidence-based service delivery. Then the quality assurance of Ayush medicines and its procurement system, including labeling and packaging. The procurement bottlenecks, delays in the procurement processes, inconsistency in medicine pricing between the government and private vendors, weak supply chain mechanisms. A lot of things we have two eminent speakers in this session, particularly Sri Ranjit Puranik ji as well as Shastri ji, who have actually very specifically addressed many of these issues and how to identify the quality as a backbone of Ayush medicines, and based on that, how we can effectively make a procurement system. Irregular medicine supply, states reported frequent disruptions in timely and smooth delivery of medicines to facilities, quality testing gaps, limited capacity of departmental testing laboratories, underutilization of NABL accredited labs despite their availability, infrastructure issues, inadequate district medicine storage infrastructure. Some of the states, very bigger states like suppose Madhya Pradesh and UP, whether you have a warehouse at the district level for the, because many of the time state level procurement and uniform distribution make a lot of delays. So based on that, whether you can think about any district level warehouse so that the medicine supplied is actually equally distributed all the warehouses and from there it is locally distributed. So such a system you can think about that. Budgetary constraint, insufficient allocation of regular drug sampling, inspections and surveillance activities, branding and packaging deficiencies, lack of standardized branding, modern packaging and promotional measures. So the bulk packing and other things, how it is actually making problems as far as the quality is concerned, already flagged in the morning issue by Dr. Upadhyay also. So these issues are very pertinent as far as the quality of the medicines are concerned. Then the procurement system, the suggestions we got, develop transparent SOPs for procurement, ensure fair price mechanism and implement real-time e-inventory tracking to reduce delays. There also expand the upgrade the drug testing laboratories, utilize NABH accredited laboratories for compliance, allocate dedicated funds for regular sampling and inspections, enhance supply chain, ensure smooth and timely medicine supply by strengthening logistics. Supply chain management is very important, and accordingly the digital tracking is also, many of the states have started it, but there is a need of uniformity, and accordingly entire country can have a uniform structure for the tracking of the supply chain. Then similarly, standardize branding and packaging, introduce uniform package standards and enhance branding strategies, and promote Ayush medicine to modern marketing approaches. Even raw material assurance, encourage establishment of herbal gardens and local cultivation to ensure availability of quality of raw materials, awareness and trust building, run campaigns on the safety, efficacy and quality assurance of Ayush medicines to improve public confidence and uptake. And as far as safety is concerned, Ministry has taken several documentation as far as the various plans and herbs are concerned, and states also should promote and propagate these safety documents wherever in the public domain it is possible, so that at least the faith of the traditional medical system can be taken into appropriately in the public domain. Strengthening the drug enforcement mechanism with qualified drug inspectors, regulatory staff and technical experts. Upgradation of the drug testing laboratories by providing high-end equipments like HPL, gas chromatography, AAS, then development of SOPs for various regulatory functions and testing, strengthen ADR reporting, this Ayush Suraksha portal, as well as the ADR reporting, the pharmacovigilance program, which has been nodal center by All India Institute of Ayurveda. You have all the peripheral centers in the entire country, so you can have that kind of linkage with that institution, so that any kind of adverse reporting can be encouraged, so that it will be appropriately recorded and examined. Then create integrated digital data platform for procurement, inventory and distribution monitoring. Then the last theme was the IT-enabled digital visas in different sectors. The basic changes what the group saw is limited integration with workflows, uneven adoption, weak rural and tribal coverage, low digital literacy, few refresh trainings and HR documentation gaps, duplication of data, poor interoperability and weak Ayush-specific EMR features, connectivity or infrastructure deficits and manual reporting persists, weak impact evaluation, slow NABH regulatory compliance and scalability issues, procurement, inventory and supply chain systems underdeveloped, limited MSME participation, funding dependency and unclear revenue models, privacy and confidentiality concerns, urban-rural disparity and low global visibility. The suggestions emanated for the IT is actually expanded training of digital LMS and CPD and district hubs, promote international collaboration and CSR or MSME models, customize telemedicine, integrate with ADM, EHR and ensure offline access, standardize HR fee and procurement system with dashboards, use AI, GIS, blockchain or FR tools for diagnostic monitoring HRMIS, enhance IEC through multi-channel outreach, community media and regional languages, create unified Ayush digital platform with a grievance reversal and privacy safeguards. Ministry of Ayush through Ayush Grid is actually trying to integrate all this IT network, and we intend to make a broad architecture of the entire IT ecosystem. So many of the state governments are already initiated these various IT enabling provisions actually. So we can have that convergence. So that is why we suggested that all of you are invited to this IT workshop, which is being held in the month of 16th and 17th of September at 18-19 of September in Kerala. Yes, Kottayam. Then outcomes and way forward, adopting AHMIS in all tiers of healthcare facilities, integrating the supply chain logistics for efficient and procurement mechanism, training and capacity building of all stakeholders on IT solutions in NAM, IT-enabled monitoring tools for effective management of construction-related activities and outcomes of public health programs, wider adoption of IT tools for learning management system and IECBCC campaigns. So, in a nutshell, these a very elaborative manner, we got various recommendations and suggestions and way forward. So what we will do, we will segregate these suggestions and recommendations into whatever which are actually, there are certain provisions in the National Ayush Mission that is required to be scaled up. There are new provisions which are required to be added, and there are certain things which is already there, only the state has to implement it. So in this way, we can categorize, and accordingly we can make appropriate recommendations to the authorities, so that at least we can, for a future of the National Ayush Mission, for making the Vikasit Bharat, we expect with your cooperation we can strengthen the mission in letter and spirit. Thank you all.
Thank you, Dr. A. Raghuji, DDG, Ministry of Ayush, for encapsulating and presenting the summary of the proceedings of the summit. Thank you so much. And now for the keynote address, may I request Professor Bhushan Patwardhanji, Professor Savitribai Phule, Pune University.
Namaskar. First, let me thank Ministry of Ayush, especially Secretary Rajesh Jucha. His baby steps have taken giant leaps for the Ministry of Ayush. And I have been associated with first department, so almost for 20 years. And I've seen how the whole thing had changed during last 5-6 years. And whole team, not only secretary, but the kind of capacity building which he has done over the whole ministry is really commendable. I so much enjoyed all the deliberations from representatives of states and UTs who have come from all over India. And I have learned quite a lot. As a professor of health, I will share very quickly some of my thoughts and reflections. You will agree that there have been tremendous advancements in biomedical sciences. I am a biochemist, and I'm not an Ayurvedic practitioner, nor am I an allopathic practitioner. So I keep all the disciplines at distance and try to look at them dispassionately. But despite these advances, if we ask a question, have we really achieved health? To me, we are trapped in what I call it as a trap of a healthcare. Because we talk about healthcare, but are we really giving healthcare is a question. Because this healthcare is a Western notion which we have adopted. And primarily, there is a tremendous amount of, even now, the colonial impact on our mind, that we are not able to really relook at our own swasthya sankalpana. I have also worked with a couple of other countries, and even the WHO definition, we have argued that WHO definition, if you look at, there is a principle in management: what you can measure, you can manage. So in the definition of health, of the WHO, we are talking about two sets. One is the pathology-oriented, disease-oriented part, and other is well-being-oriented part. So disease-oriented part, pathological-oriented part, it is very easy to measure, and therefore entire focus has gone in that. Well-being, we have not yet been defined well-being. And so if we are not able to define or measure what well-being is and how do we measure it, so the whole problem is the current healthcare layers, which all of you know, primary, secondary, tertiary, quaternary. We are saying that if we try to imagine this as a pyramid, the base of the pyramid is actually primary care. That's the base of the pyramid. And if you look at who is actually delivering that, or who has capability to deliver that, it is Ayush. And not only primary care base of the pyramid, just below that also as a strong foundation is family empowerment and community empowerment, that the principle of taking your health in your own hand, like this kind of a principle. Ayush is the best in these approaches. So, but at the same time, when you look at the resources, because all of you are dealing with resources, and I have been hearing about your ground level problems also all of you have been facing. But look at the resources now. Pyramid, top of the pyramid may be quaternary transplants. Base of the pyramid is primary care. Base of the pyramid is maximally delivered by Ayush. And now you come to the resource, the pyramid gets reversed actually. The least of the resources are coming to Ayush, and maximum of the resources we are spending on that high-tech deliverables. And again, we have got a notion that by taking medicine, we will get health. We are using health and medicine as synonyms, for some reason. Medicine is when you will lose health, and there are only 4 determinants of health, and out of these 4, 3 are completely in our control, and they are nutrition, lifestyle, environment, and the 4th one is genetics. We may not be able to really do much about it, but when all these 4 pillars, of a building, if one of them becomes weak, you need some kind of support system to stabilize the building, and that support system is medical care. And we're looking at medical care as the main object in this whole process. So there is a big need for a mindset change. And I think for India, we need more family physicians. I always say that when a family physician will get a glamour of a cardiologist or neurologist, at that time we will be going better towards the public health, And super specially, every MBBS doctor, if every MBBS doctor is aspiring to become MD and every MD is aspiring to become MCA, who is going to look after people? That question also we have to ask in this current situation. We have to go really beyond medicine. Today we are actually what we call it as a medicalized society. We are actually living in a medicalized society, and globally, if you see, top of the top journals have come out with their own campaigns, and the campaign names are less is more. Now the new approach is if you give less medicine, it will be more effective if you are able to really do it in a precision manner. So this beyond medicine, meaning medicines are necessary. But medicines are there when you are going to lose health or when you are encountering in the disease. That doesn't mean we have to get trapped into a symptomatic cure-centric society. We should get out of that. I am also a member of the Lancet Citizen Commission, and our report is going to be finalized soon. In next 2-3 months, you will find that report. When I started working in the commission, in the beginning, I was in minority, talking about Ayush. But I must tell you that there is a great appreciation even at the global level, and you will find some of the reflections, at least that negativity has gone, and now people are looking at Ayush in a very much positive manner. Next point I want to make is, and that point was made in a different way, Dr. Paul, about the health span and the lifespan. The recent report published in Journal of American Medical Association, JAMA, it is telling that the gap between the health span and lifespan is widening. And what does it mean? And why it is widening? And what should we really do about it? I must tell you that current modalities, whatever we have today in biomedicine, are not enough to take care of that. You may be able to really improve or increase the longevity, but the quality of adding life to years is something Ayush only can do. And I was happy when Dr. Raghu was presenting, and I mentioned this to Rajesh ji also, that he used term allopathy all the time, And I think that's the correct word. Modern medicine is not the correct word. And I always say that medicine will become modern medicine when allopathy will walk along with Ayush, bringing strains of each other in the best interest of people. Today, again, we are trapped in what I call it as a war of turf. This is my turf. Nobody should enter. But who is going to take care of people on the road? They are looking at, they don't bother about which pathy you come from. Whatever they want, so we should really look after their needs and not get into war of. I will not talk much about prevention motion because that is taken, and I could see that kind of resonance all over. And we must change our policies and priorities, bring them back on prevention and promotion. So there is a very good agreement and resonance on that. We must empower families, not only family physicians, we need family physicians, and we must have more family physicians than cardiologists or neurologists, but empowering families and empowering communities to take care of their own health, which Ayush can do with great efficiency and knowledge, And the last thing I want to mention is we have to change our own conceived Western notion of evidence. Evidence-based medicine, you will be surprised to know that there is a huge data available that many of the clinical trials are not reproducible. There is a data published in peer-reviewed journals which tell you that many of the clinical trials which have been supported by sponsors, the results have gone in favor of the sponsors. Similar kind of results we have seen when lot of papers published in support of tobacco industry at one point in time, And similar kind of thing is happening in front of us. So we have to really look at evidence from a dispassionate angle, Evidence is not something which we think as evidence. It is not only empiricism which will come to. So we have been arguing that even science also should grow. And science also should transcend into what we call it as meta-science. Because what we can only measure or see or hear through our senses, we think that it's only true, and we cannot, it is not. So it is contra to what Ayurveda is saying, Because Ayurveda, the kind of different kind of approaches which when I discuss with my Ayurveda colleague, and I have learned whatever Ayurveda is from all my colleagues, including Rajeshji. Those who have not read his book, you must read the book written by him on Ayurveda. I found that is one of the most simple book for non-Ayurvedic people will be able to introduce Ayurveda in a most scientific and classical manner. So idea of evidence, once we change the idea of evidence, then our approach to look at Ayurveda or Ayush also will change. And I think that will bring a new revolution. That will bring a new opportunity for India to present our own heritage in a more scientific, pragmatic, and acceptable manner, not only for our people, but also for the world, because the world needs it today. World needs it because advanced countries also, most respected and most reputed and scientifically advanced countries also today are facing a big problem of health. Simple things, simple looking things, people are not able to really resolve, which we have strengths in our own country. We should build it. I can see that happening very, very strongly under the leadership of Minister of Ayush, and all of you, whatever I have heard and seen, passionately working in your own regions, in your own states for this cause, for the people, is commendable. I salute you, all of you. Think all the best to you. Namaskar, Jai Hind, Jai Dharmantari.
Thank you, Professor Bhushan Patwardhan, for sharing your views, your thoughts with us. Ladies and gentlemen, Professor Bhushan Patwardhan from Savitribai Phule, Pune University. And may I now have the privilege of inviting Secretary, Ministry of Ayush, Government of India, Ved Rajesh Kotecha ji, and request to kindly address the gathering.
Learned dais, Professor Patwardhan ji, Professor Gangadhari, Professor Manjusha ji, Professor Bejan Mishra ji, Sri Ranjan Kumar ji, Sri Ranjit Pranik ji, Bhavna Prasad जी, सबसे पहले तो मैं नेशनल मिशन की पूरी टीम को कॉम्प्लीमेंट देना चाहता हूँ, खास करके कविता जी के लिए। आप विशेष रूप से, ये कविता जी की विशेषता क्या है कि सी इज बिहाइंड, सामने नहीं दिखेंगी। उनका मैं काफ़ी समय, अब तो 4 वर्ष हो गए कविता जी, 4 वर्ष से इनके साथ काम कर रहा हूँ, और आई हैव सी प्रैक्टिसेस कि कहीं ईगो यहाँ न पहुँच जाए, तो उसको वो प्रैक्टिस करती है। एंड सो शी इज़ ऑलवेज डाउन टू अर्थ, ऑलवेज सो हम्बल एंड सिंपल। इसलिए इस पूरे कार्यक्रम में 2 दिन में वो आगे भी अपने को तैयार नहीं थी, पहली बार आगे बैठा वो देख रहा हूँ मैं। सो माई कॉम्प्लीमेंट्स टू कविता जी एंड हर टीम, हर लेफ्ट राइट, अंजन और सुरेश, वो पूरी पीएमयू की टीम को बधाई देता हूँ, अपने नेशनल आयुष मिशन की टीम को, फॉर कंडक्टिंग एंड क्यूरेटिंग सच ए वंडरफुल प्रोग्राम, वेरी आउटकम ओरिएंटेड एंड वेरी कॉम्प्रिहेंसिव। इतना मैं लगातार जितना भी समय मिला मैं यहाँ रहा, एक्सेप्ट कपल ऑफ सेशंस में समय यहाँ रहा, और मुझे भी कुछ काफ़ी सीखने को मिला। दैट इज़ व्हाट आई इज़ माई कॉम्प्लीमेंट्स। दूसरी बात मैं ये करना चाहता हूँ कि कविता जी ने एक सुनिश्चित किया कि हमारे लीडरशिप ही जो इंस्टीट्यूट्स के लीडरशिप है वो भी यहाँ रहें। कल के दिन में तो हमारे काफ़ी लीडरशिप थे, आज भी अभी उपस्थित हैं। एक बार मैं आपका हमारे लीडरशिप से परिचय करना चाहता हूँ। इसका कारण है कि आप जरा इनको देख लें, फिर उनके पीछे पड़ें कि आप आपके स्टेट के लिए इनका क्या उपयोग करते हैं। तो मैं चाहता हूँ कि हमारे सीईओ साहब है, हमारे एडवाइज़र साहब है, हमारे फार्माकोपिया कमीशन के चेयरमैन, हमारे डीजी साहब हैं, आप जरा एक बार खड़े हो जाओ, मैं आपका सबका परिचय करा दूँ। सब हमारे नेचुरोपैथी इंस्टीट्यूट के हमारे पुणे के डायरेक्टर मैडम हैं सत्यलक्ष्मी जी। सत्यलक्ष्मी जी शायद गए, उनकी फ्लाइट वगैरह होगी। और कोई हमारे लीडर्स कोई इसमें हमारे कोई मेरा ध्यान न हो ऐसा कोई है जो? हाँ, हमारे डीजी रिसर्च काउंसिल ऑफ सीधा। तो देखिए ये हमारे लीडर्स हैं। कल हमारे रिसर्च काउंसिल के बाकी लोग भी थे, हमारे बाकी एडवाइजर भी थे। तो दे आर नॉट डायरेक्टली रिलेटेड नेशनल आयुष मिशन, लेकिन आप जरा आपके क्षेत्र में आप देखिए कि इनका आप कैसे इनके साथ सहयोग करके, संपर्क करके उनके पास से अपने राज्य के लिए कुछ काम करा सकते हैं। जैसे हमारे सुभाष कौशिक जी हैं, आप हमारे रिसर्च काउंसिल जो होम्योपैथी की है, सेंट्रल काउंसिल फॉर रिसर्च होम्योपैथी, उसके आप डायरेक्टर जनरल हैं और काफ़ी सुविख्यात वैज्ञानिक है होम्योपैथी के क्षेत्र के। और होम्योपैथी के क्षेत्र में स्टेट का कुछ कोलैबोरेशन चाहिए तो आप उनसे संपर्क करिए, ही विल बी वेरी हैप्पी टू कोलैबोरेट। जैसे हमारे रिसर्च काउंसिल सीधा के हमारे डॉक्टर मुत्तु कुमार जी हैं, ही इज बेस्ड चेन्नई, और वो तमिलनाडु और दक्षिण के राज्यों के लिए आपको सीधा में कोई कोलैबोरेशन करना है तो आप जरूर उनसे संपर्क करिए। आई वुड सजेस्ट दैट मुत्तु कुमार जी, you should reach out to the states and then offer your help and services। जैसे पब्लिक हेल्थ के रिसर्च में हमारे पास काफ़ी कुछ एक्सपर्टीज नहीं है, तो रिसर्च काउंसिल उसमें हेल्प कर सकते हैं। हमारे एडवाइज़र कौस्तुभा जी है, कौस्तुभा जी ने एक अच्छा काम इन 2 दिन में जो करवाया, वो बेजोन मिश्रा जी को लेके आए, वो यहाँ आइया में इन्होंने PME शुरू करा दिया, तो मेरे खूब आपको बधाई हो। जो इंश्योरेंस सेक्टर है आयुष का, अभी चीज़ें कैसे शेप होती है मैं उदाहरण देता हूँ कि कौस्तुभा जी ने पीछे पढ़ के ये सब कराया। कल ये शुरू हुआ, बेजोन मिश्रा जी आए। बेजोन मिश्रा जी कहाँ रुके थे, उनको एक GIC अपने जनरल इंश्योरेंस काउंसिल के चेयरमैन मिल गया सुबह। तो उन्होंने चेयरमैन साहब को ये कहा, तो ही वॉज वेरी एंथुजियास्टिक कि मैं सभी इंश्योरेंस कंपनी को ले आऊँगा, एक बार राउंड टेबल कर लेते हैं। तो दैट इज द काइंड ऑफ आउटकम कि हम जो कुछ काम करते थे कुछ इसमें आगे आगे बढ़ता जाता है। तो माई कॉम्प्लीमेंट्स। और कर्नाटक के हमारे कौस्तुभा जी कर्नाटक से हैं, तो कर्नाटक के लोग जरा इनके पीछे पड़े, आपके कर्नाटक के बहुत सारे काम पेंडिंग होते हैं, तो आप उनका लाइजनिंग करें, जरा उनसे संपर्क करें। हमारे CEO हैं नेशनल मेडिसिन प्लांट बोर्ड डॉक्टर दादी जी। एक विचार जो है, जो माननीय मंत्री जी ने भी कहा कि हमारे पास एक सेंट्रल सेक्टर स्कीम है हर्बल गार्डन की, उसका हम कन्वर्जेंस आयुष्मान आरोग्य मंदिर में कर सकते हैं कि नहीं, जरा चेक करिए, क्योंकि उसमें हमारे हर्बल गार्डन कंपोनेंट आम में बहुत प्रभावी नहीं है, उनके पास उसका इकोसिस्टम है, स्कीम है। तो राज्यों को मेरा निवेदन है कि आप उनसे संपर्क करके अपने आयुष्मान आरोग्य मंदिर के लिए कुछ हर्बल गार्डन का कुछ कंपोनेंट इनसे सहायता ले सकते हैं, तो जरा इनको आप जरा अप्रोच करिए। हमारे फार्माकोपिया कमीशन के डायरेक्टर हैं, आपका काम है सभी फार्माकोपियल स्टैंडर्ड्स को पब्लिश करना, उसको लगातार अद्यतन रखना, अपडेट रखना। अब जो स्टैंडर्डाइजेशन की बात हुई, और जो भी हमने जो यहाँ पर ड्रग स्टैंडर्ड पर जो सुबह का सत्र हुआ, उसमें इनका बड़ा रोल है। इनका रोल ये है कि ये सभी स्टैंडर्ड्स को सुनिश्चित करने के लिए सबसे बड़े आदमी है भारत सरकार के, तो जरा आप उनका भी मार्गदर्शन लीजिए। मेरा सुझाव है कि कभी आप गाजियाबाद में आएंगे तो इंस्टीट्यूट देखने चाहिए, बहुत अच्छा, इनके पास बहुत अच्छी लेबोरेटरी है वर्ल्ड क्लास, और उनके पास बहुत अच्छा हर्बल गार्डन भी है। आपके राज्य में कुछ आयुष कॉलेजेस हैं, उनका विजिट इनके लैब में कराइए, क्योंकि उस बच्चों को पता चले कि इस प्रकार का इकोसिस्टम है, और ऐसे इस प्रकार के रेगुलेशन स्टैंडर्ड के क्षेत्र में भी, स्टैंडर्डाइजेशन के क्षेत्र में काफी बड़े काम हो रहे हैं। तो मैं ये विस्तृत रूप से परिचय करना चाह रहा था हमारी लीडरशिप का। एक जो भूषण जी ने कहा, मैं उसमें जरा थोड़ा और, क्योंकि ये मेरा प्रिय विषय है। आपने कहा कि आपने टच किया उस विषय को कि जो एविडेंस, हाई एंड एविडेंस की बात होती है, एंड यू नो इट इज ऑलवेज मेंशन्ड दैट द एविडेंस इज व्हाट विच इज रिप्रोड्यूसिबल, एंड सो उन्होंने इसको मेंशन किया। मैं उसको आगे थोड़ा और जानकारी देना चाह रहा हूँ कि देयर आर कपल ऑफ पब्लिकेशंस, हाई एंड पब्लिकेशंस इज बेस्ड ऑन मेटा एनालिसिस। मेटा एनालिसिस का मतलब क्या होता है, बहुत बड़े बड़े जर्नल में जो पब्लिकेशन होता है उसको सब लिख करके उसका सार पब्लिश होता है कि इसमें सबको मिला करके इसमें से क्या आउटकम हम निकाल सकते हैं, क्या इन्फरेंस निकाल सकते हैं। वन मेटा एनालिसिस इज अबाउट हाउ मच इज द रिप्रोड्यूसिबिलिटी ऑफ द हाई एंड डबल ब्लाइंड प्लेसिबो कंट्रोल स्टडीज ऑन ड्रग रिसर्च, and that was done based on the high-end journals like Lancet and American Journal of Medicine, etc. and EMJ. और उसमें पता चला कि more than 50% of such publications, the results are not reproducible. More than 50%. तो ये बहुत बड़ा है। हम लोग सब बातों में आ जाते हैं, लेकिन एविडेंस तो कई तरीके के होते हैं। नाउ वी आर इन द एरा ऑफ हाई एंड कंप्यूटेशनल बायोलॉजी। कंप्यूटेशनल बायोलॉजी में आप, जैसे आपने भी अय्या में भी वो उन्होंने स्थापित करी है। आई एम सो हैप्पी कि बहुत सारे बड़े बड़े मेडिकल कॉलेजेस में लैब न हो, जैसा इन्होंने अय्या में स्थापित किया है। हाई कंप्यूटेशनल बायोलॉजी में आप ज़्यादा इन्फरेंस निकाल सकते हैं, एंड देन यू कैन गेट अ लॉट ऑफ एविडेंस थ्रू large scale AI based ecosystem, then randomized control style. तो साइंस तो इवोल्विंग होता है, हमेशा नया नया काम होता है, तो किसी एक चीज पर हमारी सुई अटकनी नहीं चाहिए। तो इन्होंने कहा, इसको थोड़ा इस प्रकार से बता रहा हूँ। एक दूसरा उन्होंने कहा कि जो पॉजिटिव इन्फ्लुएंसेस होते हैं पब्लिकेशंस में, उस साथ उसका फंडिंग का भी एक स्टडी हुआ है। उन्होंने उसको टच किया, मैं उसको स्पेसिफिकली बताना चाह रहा हूँ। देयर इज अनदर meta analysis about relationship of funding and positive outcome in drug research, and it was found that 69% of privately funded, multinational corporation funded drug research outcome, the hypothesis was true as per the publications, and only 31% publications where the public funding or non-profit funding was there, and the hypothesis was true in 31%. So between the lines हमें समझ में आती है कि ये जो हम अंग्रेजी में बड़े बड़े एविडेंसेस देखते हैं, बहुत पब्लिकेशंस की बात करते हैं, उसमें हम लोगों को जरा और गहराई में जाना चाहिए। और आइडियली तो क्या है कि जो आता है उसको एकदम से मानने के बदले उसको क्रिटिकली देखना चाहिए। दैट इज द काइंड ऑफ अंडरस्टैंडिंग। मैं इसलिए कहा कि ये हमारे देश के दो सबसे बड़े स्टार यहाँ बैठे हैं, तो मैं उनके लिए भी मैंने कहा कि हमारे डॉक्टर गंगाधर जी भी यहाँ पर है, प्रोफेसर वर्धन जी भी, इस एरिया में उनका भी काम है। एक अभी जो मेरा सुझाव है हमारी टीम को, मिनिस्ट्री की टीम को, नेशनल आयुष मिशन की कविता जी एंड हर टीम, कि हम लोग अभी वी आर द प्रोसेस ऑफ फाइनलाइजिंग द EFC नोट फॉर द नेक्स्ट साइकिल। 5 साल के लिए नेशनल आयुष मिशन को आगे बढ़ाएंगे, उसमें हम लोगों को काफी बढ़ पर इसकी तैयारी कर रहे हैं। ये 2 दिन का कॉन्क्लेव और अपना लोनावाला का अपना जो नेशनल आयुष मिशन का कार्यक्रम हुआ, 2 दिन का मंथन हुआ, ये दोनों में हमारे पास स्टेट्स का बड़ा भारी, बहुत ज्यादा मतलब डाइवर्स थॉट प्रोसेस से बहुत अच्छे अच्छे सजेशन आए हैं, और बहुत उपयोगी सजेशन है, बिकॉज these suggestions came from the field. The real-time people is working actually in the field. They are actually having a lot of practical suggestions of implementation of this scheme. So my request to the team is, please look at this, resource, the golden kind of resource for us to have a new, scaled up and high impactful scheme for the next cycle. I'm sure it will happen. Already आपने तैयारी शुरू करी, मुझे पता है. एक जो प्रोफेसर पटवर्धन जी मेंशन किया, फैमिली शुड बी एम्पावर्ड. कई वर्षों से मैं भी इनके साथ काम, इन्होंने कहा मैं आपके साथ करूं, मैं उनके साथ काम कर रहा हूं, दोनों एक दूसरे के साथ काम कर रहे हैं. तो वर्षों से ये प्रोसेस के ऊपर हम सब लोग मिलकर काम कर रहे हैं. बहुत सारे वैज्ञानिक, हमारे नीति आयोग उसमें काम कर रहे हैं. The thought is कि हम जब हेल्थ की बात करते हैं, प्रमोशन ऑफ हेल्थ, प्रिवेंशन ऑफ हेल्थ, तो हेल्थ इज नॉट ए मेडिसिन दैट ही हैज एक्सप्रेसली मेंशन्ड एंड डेलिबरेटेड. मैं उसकी फर्दर चर्चा नहीं करूंगा, लेकिन यदि हेल्थ को हमें आगे बढ़ाना है, स्वास्थ्य को, जिसमें चिकित्सा नहीं है, स्वास्थ्य है, तो फैमिली को अपने को एम्पावर करना पड़ेगा. तो वी मे कॉल इट एज ए फोर्थ टायर ऑफ हेल्थ केयर. वी हैव 3 टायर ऑफ हेल्थ केयर, प्राइमरी, सेकेंडरी, टर्सरी. दिस इज फोर्थ टायर ऑफ हेल्थ केयर, जहां हम फैमिली को एम्पावर करें एंड फैमिली को बिहेवियर चेंज कम्युनिकेशन, साइंस बेस्ड बिहेवियर चेंज कम्युनिकेशन से हम उनको एम्पावर करें कि आप अपने स्वास्थ्य की खुद चिंता करो, आप ठीक से निद्रा लो, ठीक से न्यूट्रिशन लो, और आप व्यायाम करो, आपकी लाइफस्टाइल ठीक रखो, आप बीमार नहीं पड़ोगे. प्रोफेसर पटवर्धन जी ने जेनेटिक्स की बात करी. इसमें मेरा मैं ये नहीं कहूँगा मेरा डिफरेंस ओपिनियन, लेकिन उन्होंने इसको आगे ये कहा होता, क्योंकि आपका ही काम है जो कोट कर रहा हूँ, कि जेनेटिक्स में भी एपिजेनेटिक्स है. आयुर्वेद में प्रकृति में कहा है प्रत्यात्म नियत, उसके बाद प्रकृति के ऊपर इम्पैक्ट करने वाले बहुत सारे फैक्टर्स बताए, देश काल, जाति, कुल वगैरह. तो even if we have particular genetics, it is impacted by lifestyle, by our environment, by our emotional quotient, by our family, by our friends. तो एपिजेनेटिक्स ऐसा एरिया है जिसमें हम लोग बहुत मिलकर काम कर सकते हैं. Even if somebody is genetically susceptible, there are evidences कि किसी फैमिली में डायबिटीज यदि ससेप्टिबिलिटी है तो सबको डायबिटीज नहीं होता, कई लोगों को होता है, 2 को नहीं होता. Why it is happening? Because possibly this person who is not getting it have some specific amendment in lifestyle, या उनका कोई ऐसा कोई उन्होंने एफर्ट किया है जो जिसके कारण डायबिटीज नहीं हुआ. तो कुल मिलाकर के जो मैं कह रहा हूँ ये बहुत कॉम्प्लेक्स है. इट इज नॉट दैट सिंपल. बट इफ वी एम्पावर द फैमिली टू टेक केयर ऑफ देमसेल्व्स एंड देयर फैमिली बाय लार्ज स्केल बिहेवियर चेंज कम्युनिकेशन, तो हमारा देश का स्वास्थ्य का इकोसिस्टम पूरा चेंज हो सकता है. कविता जी ने सुबह कहा कि हम लोग घर आयुर्योग लेके आ रहे हैं. इसके बारे में आपसे पहले कंसल्टेशन भी किया है. हर घर आयुर्योग का मतलब सिर्फ आयुर्वेद और योग नहीं, सभी आयुष विद्या और योग. अब लोग यदि ये विजडम जो है हमारे घर में, उस विजडम को थोड़ा सा साइंस बेस्ड बना करके, एजेंसीज को उसमें डाल करके यदि एक लार्ज स्केल बिहेवियर चेंज कम्युनिकेशन करते हैं, जैसे स्वच्छता का हुआ, जैसे हर घर जल का हुआ, ऐसे यदि हम इसको करते हैं तो पॉसिबली वी हैव possibility of getting a very very large impact on people's lives to make them healthy. अभी तो माइंडसेट ये है कि हम जरा सा भी पढ़ते तो कोई गोली ले लेते हैं, एंड देन वी आर पील मेकिंग सोसाइटी. तो पील मेकिंग में से हम स्वस्थ रहने के लिए दवा लिए ना कैसे इसको कर सकते हैं, उस पर काम करने का एक संकल्प आयुष मंत्रालय ने लिया है और हमारी टीम उस पर काम कर रही है. राज्यों से मेरा निवेदन है कि आप इस विषय में और हमें गाइड करिए. इस विषय में आपसे हमें और इनपुट्स चाहिए. ये जो इनपुट्स आपने बताए, दे आर ऑल वेरी गुड. लार्जली द सजेशंस आर रिलेटेड टू लॉजिस्टिक्स, लेकिन इसमें हमें थॉट लीडरशिप भी चाहिए आपकी तरफ से. आप हमें ये बताइए कि बिहेवियर चेंज कम्युनिकेशन करना हो तो इट शुड बी रीजनल स्पेसिफिक. हमें इसके पैकेज बनाने पड़ेंगे, इसको वेग नहीं चल सकता. मतलब वी हैव टू क्रिएट ए पैकेज ऑफ पर्टिकुलर एरिया ऑफ हेल्थ एंड देन डिलीवर दिस पैकेज. तो ये सब चीजें, पैकेज मतलब इंश्योरेंस पैकेज नहीं सर. आई एम ट्राइंग टू कन्वे दैट इफ वी वांट टू प्रिवेंट डायबिटीज, देयर इज ए पैकेज ऑफ हाउ टू प्रिवेंट डायबिटीज. If somebody is diabetic, what lifestyle modifications they are required to do? This is a package. इससे हम लोगों को आईसी पैकेज बनाने पड़ेंगे, ऐसे बहुत सारे काम हम लोगों को करने पड़ेंगे। आपकी मदद के बिना आप कैसे कर पाएंगे? तो मेरा सभी स्टेट से निवेदन है कि आप अपने अपने राज्यों में वापस जाकर के आपकी टीम के साथ बैठिए, इस पर मंथन करिए, हमें बताइए कि हमें क्या करना है। थोड़ा आपके पास से इसका मार्गदर्शन चाहिए। आप जितना जल्दी करेंगे उतना अच्छा है, क्योंकि अभी हमारे पास उसका सीजन आ गया है, क्योंकि उसका जो थर्ड पार्टी असेसमेंट होना था नीति आयोग तरफ से नेशनल मिशन की स्कीम का, वो भी हो गया। नाउ वी आर सपोज टू डिलीवर एंड प्रोपोज EFC नोट विद इन 1 मंथ मैक्सिमम, 4 सप्ताह में देना पड़ेगा। उसके बाद उसका लार्जर कंसल्टेशन होता है, IMC होता है, उसके बाद कैबिनेट तक पहुंचते पहुंचते मार्च से पहले तो हमें इसको लॉन्च करना है। तो जनवरी या दिसंबर में हम इसका अप्रूवल नहीं लेंगे तो लॉन्च कैसे करेंगे मार्च में? तो ये टाइमलाइन भी है सब, है ना। तो ये आज का जो 2 दिन का जो कॉन्क्लेव है, ये कॉन्क्लेव ने हमें एक इंसाइट भी दी है, बहुत सारी दी है, एक नहीं बहुत सारी इंसाइट दी है। बट वी वांट मोर, जिसको कहते हैं दिल मांगे मोर, तो वी वांट मोर फ्रॉम यू। आप जरा एक बार स्टेट्स को निवेदन है कि आप जरा अपने अपने राज्यों के स्पेसिफिक कुछ सुझाव हो, क्योंकि दिस सजेस्ट कुड बी इवन रीजन स्पेसिफिक। हमारा देश इतना बड़ा है कि what lifestyle we are following and food habits is different. Even if go 100 kilometers south or north or west, things go different. तो ये one size fits all वाले solutions तो हम ला नहीं पाएंगे। तो इसमें हमें काफी बड़ा काम करना पड़ेगा। अंतिम बात, ये सुबोध कुमार ने, हमारे डायरेक्टर ने एक प्रेजेंटेशन किया था। सेक्टर ग्रुप ऑफ सेक्रेटरीज के जो ग्रुप्स हैं, सोशल ग्रुप एंड टेक्नोलॉजी ग्रुप, उसके प्रेजेंटेशंस हुए थे। एंड आई विल रिक्वेस्ट माय टीम शेयर विद दिस स्टेट सो दैट दे कैन गिव स्पेसिफिक सजेशन। उसमें मैं इसको ऐसे देखता हूँ कि दिस इज एन अपॉर्चुनिटी फॉर दिस सेक्टर, क्योंकि ऑलरेडी क्यूरेट हुआ है, इट इज अलाइन विथ 2047 में आयुष क्षेत्र को कहाँ जाना है उसका मैपिंग हुआ है। विकसित भारत में आयुष क्या स्थान होगा, हमने कमिट किया कि वी विल कंट्रीब्यूट टू 5% GDP बाय 2047। तो 5% GDP को कंट्रीब्यूट करना होगा तो काफी बड़ा सोचना पड़ेगा। अभी हम 1% दे रहे हैं, 1% इज नॉट स्मॉल, बट वी आर रीच एट 1%। तो 1% में 5% तो 5 गुना ही तो हुआ। आप इसे देखो तो 5 गुना कौन सी बड़ी बात है। हम 10 साल में 8 गुना हैं, तो 2047 तक 5 गुना ही तो करना है, बट इट इज ह्यूज। तो उसके लिए जो 5 साल का कार्यक्रम है, इट इज एग्रीड बाय ग्रुप ऑफ सेक्रेटरीज एंड इट इज प्रेजेंटेड इन फ्रंट ऑफ काउंसिल ऑफ मिनिस्टर्स। तो ये पक्का है। अब इसको इम्प्लीमेंट करना है तो आप सबकी मदद चाहिए, स्टेट की मदद चाहिए, खास करके जो सेंट्रली स्पॉन्सर्ड स्कीम्स है उसको उस स्पिरिट बाय हार्ट इसको कैसे इम्प्लीमेंट करना है, इसको हम लोगों को वी रिक्वायर योर हेल्प एंड योर इंटरेस्ट फॉर द अदर थिंग्स। फॉर एग्जाम्पल, there is a proposal of establishing like institutes across the country। एक सुझाव है, तो आपकी तरफ से हमें इनपुट मिलना चाहिए। कुछ स्टेट को लॉबी करना चाहिए कि हमें दे दो, थोड़ा कंपटीशन होना चाहिए। चैलेंज मोड में देंगे तो चैलेंज मोड में कौन से स्टेट आपस में हमें भारत सरकार को कहते हैं कि हम ये जमीन दे देंगे, इतना रिसोर्स दे देंगे, तो भारत सरकार उसके लिए सोचेंगे। तो आई एम पुटिंग इन ए पर्सपेक्टिव कि स्टेट को कैसे सोचना चाहिए। भाई ये आपके पास अपॉर्चुनिटी है कि 10 इंस्टीट्यूट आ रहे, मेरे स्टेट में क्यों नहीं आएगा? उसके लिए आपको थोड़ा जोर लगाना पड़ेगा। तो मेरा सुझाव ये भी है कि आप जरा इसको दें। ऐसे दूसरे सुझाव भी है कि $200 बिलियन लेके जाना है। तो आई रिमेंबर आई मेंशन दैट सम ऑफ स्टेट हैज ब्रॉट आउट आयुष पॉलिसी, स्पेसिफिक पॉलिसी, कि भाई हम आयुष को कैसे ले जाएंगे। जैसे उत्तराखंड ने पब्लिश किया, छत्तीसगढ़ ने किया, उत्तर प्रदेश इज इन द प्रोसेस ऑफ डूइंग इट। तो ऐसे बहुत सारे स्टेट आयुष पॉलिसी लेके आए हैं, उसमें उन्होंने स्पेसिफिक क्यूरेशन किया कि हमारे पास कोई इंडस्ट्री आएगी तो हम इतना लैंड पार्सल देंगे, इतना इंसेंटिव देंगे, इतना ही वो कैपिटल इन्वेस्टमेंट करते तो इतना सब्सिडी देंगे। सो दो काइंड ऑफ थिंग्स आल्सो शुड हैपन फ्रॉम द स्टेट। आप स्टेट को, आयुष डिपार्टमेंट को, आयुष को आगे बढ़ाना हो तो दिस इज ए पब्लिक हेल्थ प्रोग्राम व्हाट वी आर डूइंग। बट अदर देन दैट देयर आर इमेंस अपॉर्चुनिटीज बिकॉज देयर इज ए स्ट्रॉन्ग अंडरकरंट इन द पीपल ऑफ इंडिया, स्ट्रॉन्ग अंडरकरंट। हमने NSSO सर्वे की बात हुई, NSSO सर्वे हुआ, उसमें 95% ऑफ अर्बन rural, and 96% of urban population have mentioned that they are aware about Ayush. Out of them, 50% has said that they are using Ayush for their health. 50% out of them. There was a criteria that minimum 1,000 rupee you are spending, then and then you report that you are using for health. So 50% means when you translate it into the figure, it becomes 70,000 crore rupee. 17,000 करोड़ का तो हमारे डोमेस्टिक मार्केट का है, जो अंडर करंट है, उसको हम कैपिटलाइज करना चाहिए. कैसे करेंगे? स्टेट का काम है. स्टेट के पास पैसा तो स्टेट के पास आएगा. तो why should not state should think about the facilitate industry, bringing in them and then handholding them. ये एक बड़ा चैलेंजिंग किया है, बड़ा अपॉर्चुनिटी वाली बात है. तो इसको भी आपको ये SGOS के उसमें सजेशन है, आप देखिए and then give us inputs. For example, some states may mention that will facilitate, by our Ayush policy to implement this to make it $100 billion. इस प्रकार के सुझाव यदि हमारे पास आते हैं तो substantiate our claim to have this 5 years vision, and then इस informal group of ministers के पास हम थोड़ा अधिकार के साथ जाएंगे, हमें स्टेट के पास भी सपोर्ट मिला है. It happens. कई बार क्या होता है कि अब मिल करके बहुत सारे एरिया में काम करते हैं तो मिल करके बड़े काम हो जाते हैं. जैसे मैं ये आपके लिए तो थोड़ा सा भूमिका बनती, दूसरा काम तो बड़ा है, मैं आपसे लेना है मेरे को. The other task is I request all of you, all the states, to please send a communication to Finance Commission from the state. Formal communication should come. The formal communication is required because when we went to have a presentation to the chairman of Finance Commission and the team of Finance Commission, our honorable minister also came. He was chairing this meeting, and then Finance Commission chairman and our minister, both of them were there. They both were chairing. I had a presentation. It was very convincing. मुझे पता है आपकी फ्लाइट. It was very convincing. थोड़ा सर को शॉल वगैरह आप थोड़ा. So, but then the comment from one of the member of Finance Commission said that हमें स्टेट से तो कुछ आया नहीं, स्टेट ने तो कोई डिमांड नहीं दी. तो that was even, they were little frustrating for us कि हमने इतना सारा पिचिंग किया लेकिन उन्होंने 1 मिनट में खारिज कर दिया कि स्टेट का तो कुछ आया नहीं. We are still hoping and we are trying. We are also, continuously in touch with Finance Commission that some recommendations should come. Our request to Finance Commission was that when they allocate a specific quantum to health for the states and local bodies, there should be some proportionate percentage of health allocation to Ayush. As per the recommendation of different parliamentary committees ने कहा अलग अलग समय पर कि 10% होना चाहिए. एक पार्लियामेंट्री कमेटी ने पहले 8% कहा था, अभी 10% कहा है. तो स्टेट प्लीज राइट टू द फाइनेंस कमीशन, प्रोबेबली योर चीफ सेक्रेटरी और if possible your chief minister should write to the finance commission that there should be a specific allocation of percentage proportion of health allocation to Ayush. And in the report of 16th Finance Commission, आप परसेंटेज 10% कहिए, सब लोग 10 कहेंगे तो 5 मिलेगा, 7 मिलेगा, कुछ तो मिल जाएगा. So my request again, please note this, and then when you send a communication, send us a copy. If it is possible, send us a CC visibly. If you don't, then just एक WhatsApp कर दो आप, and we'll collect it and then we'll again go to Finance Commission. This is very important because कितना भी बात करें, हमारे पास किटी तो लिमिटेड ही होने वाली है. अभी हमारे पास जैसे आयु मिशन का इस बार का बजट 1275 करोड़ का है, 2000 करोड़ का हो जाएगा, 3000 करोड़ का होगा मैक्सिमम, उससे ज्यादा तो नहीं होगा. वो काम इतना बड़ा है. यदि एससीपी के लोकेशन फाइनेंस कमीशन से हुआ तो स्टेट के पास से रहेगी, सो दे कैन यूज अ लॉट ऑफ इनोवेटिव आइडिया इम्प्लीमेंट इनटू आयुष सेक्टर फ्रॉम दिस किट. ये भी एक बड़ा आपसे निवेदन है कि जरा इसको देखें. जो चीजें बात हो गई उसके मैं रिपीट नहीं कर रहा हूँ, लेकिन मेरे जो 4-5 मुद्दे थे आपको बताने के लिए इसको समराइज कर रहा हूँ. एक, प्लीज राइट टू द फाइनेंस कमीशन. आप उसको हमें अगले 1 सप्ताह में भेज करके हमें कॉपी भेजिए. कविता जी को मैं रिक्वेस्ट करूंगा कि आपकी टीम को भी जरा सबको रिमाइंड करने के लिए बताइए. दूसरा, SGOS का जो प्रेजेंटेशन हुआ उसकी आपके पास कॉपी आएगी, उसके इनपुट्स दीजिए स्टेट की तरफ से। तीसरा, हर घर आयोग के लिए आपका संकल्पना चाहिए, आप इसको कैसे करना चाहते हैं एज ए फोर्थ टायर ऑफ हेल्थ केयर। मैंने आपसे रिक्वेस्ट करी, निवेदन करा। चौथा, मैं अभी कुछ ही लीडरशिप का आपसे परिचय करा। हमारे देश भर में 85 लोकेशंस पर आयुष मिनिस्ट्री का डायरेक्ट प्रेजेंस है। Either we have a national institute or we have our research council outlet in laboratory or hospital something. सभी स्टेट में, 2-3 स्टेट को छोड़कर के सभी स्टेट में हमारा प्रेजेंस है। प्लीज रीच टू अवर काउंसिल्स, अवर इंस्टीट्यूट्स एंड देन कोलैबोरेट. You can think of capacity building, you can think of having some research program, you can think of anything, and they will be there to help you. इतना आप जरा जरूर किए, एंड थैंक यू सो मच. हमारे माननीय मंत्री जी आज किसी विशेष कारण से उपस्थित नहीं थे, तो उनकी तरफ भी मैं आप सबको, उन्होंने मुझे आपको कन्वे करने के लिए कहा है कि मैं आप सबको बधाई दूं. इतना 2 दिन निकाल के आप आयुष मंत्रालय के साथ करके हम लोग बड़ा काम कर रहे हैं, तो उन्होंने अपने कॉम्प्लीमेंट्स आप सबके लिए, हम सबके लिए भेजे हैं. धन्यवाद.
बहुत बहुत धन्यवाद सचिव महोदय वैद्य राजेश गुड़ीचा जी. सचिव आयुष मंत्रालय भारत सरकार, अपने विभिन्न बिंदुओं पर प्रकाश डाला और आपने परामर्श दिया, सुझाव दिया, प्रतिक्रिया दी और साथ ही स्वास्थ्य संबंधी विभिन्न पक्षों के बारे में आपने रेखांकित किया. उन्हें बहुत बहुत आभार, साधुवाद आपको. और इसी के साथ हम 2 दिवसीय हमारा ये विभागीय समिट जिसे यहीं पर संपन्न करते हैं. आप सबका इसमें शामिल होने के लिए, फॉर योर पार्टिसिपेशन, सपोर्ट, वी आर रियली थैंकफुल, ग्रेटफुल टू ऑल ऑफ यू एंड डिग्निटरीज ऑन द डायस. आप सबका भी बहुत बहुत शुक्रिया. So I've been told that we'll felicitate our distinguished guests sitting on the dais with us. Ma'am,
मना कर रहे सर. अच्छा ठीक है. सर बेजल सर आप कहना चाहें सर?
जी आप ले आइए प्लीज, मैं अनाउंसमेंट कर देती हूँ. तो राष्ट्रीय आयुष मिशन और राज्यों में क्षमता निर्माण, इस विषय पर हमारा 2 दिन का ये आयुष मंत्रालय भारत सरकार की ओर से विभागीय शिखर सम्मेलन आयोजित किया गया. आप सब इसमें देश के अलग अलग राज्यों और प्रदेशों से धारे हैं. 2 दिन आप हमारे साथ बने रहे, आप लोगों का सहयोग हमें प्राप्त हुआ, इसके लिए हम बहुत बहुत आभारी हैं. और जैसा कि हमारे सभी मान्यगणों ने भी आपसे इन 2 दिनों के भीतर पुनः कहा कि भविष्य में भी इस प्रकार के कार्यक्रम आयोजित होते रहेंगे और आपसे हम और ज़्यादा पार्टिसिपेशन की करते हैं कि आप लोग अपने इनपुट्स भी देंगे, सहयोग भी करेंगे. इसी आशा, इसी विश्वास के साथ इस समापन सत्र के साथ ही इस सम्मेलन को हम ही संपन्न करते हैं. जी. और अब जेस मैम यहाँ पर फैसिलिटेट कर रही हैं बेजन कुमार मिश्रा जी को. थैंक यू मैम, थैंक यू सर. जी, आप सभी मान्यगणों का आभार. आप सबको भी बहुत बहुत साधुवाद, बहुत बहुत धन्यवाद. आप सबकी यात्रा जो है वो सेफ हो, सफल हो. पुनः आभार व्यक्त करते हुए मैं तपस्या लेती हूँ अनुमति. नमस्कार, जय हिंद, जय भारत. Guys, mic chega please. Sir, I'm requesting you all for the group photograph. Secretary sir, एक group photograph के लिए मुझे आदेश हुआ है. So please. So I'm requesting all the DGs and senior officials to kindly come onto the stage, please. सबसे निवेदन, आप मंच पर आएं. जो हमारे senior state और UTs के DGs and और मैं आप सबको ये भी बताती चलूँ, इसके बाद जलपान की व्यवस्था, हाई टी का अरेंजमेंट आपके लिए किया गया है. सो प्लीज़ डू जॉइन अस फॉर हाई टी Thank you once again. Thank you.
आ जाओ, मैडम बुला रही है।